And thank you to Brian for letting me exercise this to date undiscovered talent as an axe thrower. That was a lot of fun. So welcome everybody. It is my pleasure to give you an update on the Indiana Learning Health Systems Initiative, which, as you know, is one of the 3 or 4 external strategic initiatives of the Regenstrief Institute. I want to take a few minutes today to tell you what our mission is, where we are, where we see the opportunities and challenges, and most importantly, listen to your ideas about what the Indiana Learning Health System Initiative should be and become. Many of you have heard the term learning health system. There's many definitions out there. I just wanted to highlight a few key points from some of them. So obviously, it's about improvement, innovation and continuous improvement. It requires putting together a few disciplines and spheres of activities to do that. So in our case, science, informatics, strategy, and behaviors. You want to seamlessly integrate best practices into care delivery. And with a nod to Peter, and you've heard this from him several times now, I think it should be evidence-generating rather than evidence-based. What that phrase highlights is that new knowledge gets produced in practice, it gets applied in practice, and there's not the traditional division that we many times struggle with between researchers and clinicians. We're really looking at one cohesive set of activities where research and clinical care almost blend together in a very organic way. Many of you have seen this cycle for the learning health system. So this goes back to Chuck Friedman in a nod to his long tenure in biomedical informatics. You see that this diagram is quite established in terms of even visible from the Courier font that I haven't used in the last 25 years. So Chuck very smartly put together this idea of the afferent and efferent loop, and with a nod to the neuroscientists in the room, I think it makes a lot of sense when we start at the bottom here. We assemble data from various resources, and then we analyze the data by various methods. It's your afferent loop, it's the sensory system that informs you about the environment and what goes on in there. And then on the efferent side, we interpret the findings, we draw conclusions, we conceptualize interventions. We put those interventions in practice. We gather, we feed those interventions into practice, we change practice, and then the cycle begins anew. And so the idea is that this is a continual cycle that goes on and on and on, and that is organizationally and culturally a part of the operations of a healthcare institution. When you look at the mission and vision of the Indiana Learning Health Systems Initiative, and these are draft statements, mission: help healthcare delivery organizations across Indiana develop and implement a learning health systems approach, and vision slightly more grand in terms of having a real impact on the health of people in Indiana, and also hopefully beyond. So 2 questions. Why Regenstrief and why Indiana? When I look around the room, I see a lot of people who are actually engaging in learning health systems activities. Many of you have done studies that measured a clinical process or outcome and then devised an intervention to make that, to change that, to make it better. So I would hazard the statement that most of our activities And if you think back to same Regenstrief's vision for the Institute, most of our activities actually fall into the learning health systems umbrella. So we have expertise, we have a track record, and we have existing partnerships. As you know, Regenstrief has no clinical facilities. So for us to say we are leading a learning health systems initiative, by the same token, immediately means that we actually have to partner with other places. Second question, why statewide? My favorite thing to say there is walking into any healthcare setting in Indiana should really be like walking into the Cleveland Clinic. People think this is a little bit preposterous, but think about it for a moment. When you are ill with a grave problem, and you know that at the Cleveland Clinic or at Mayo or at Memorial Sloan Kettering would be the best place for you to get that problem taken care of, obviously you want to go there. But for many of us, that's not a reality. We can't afford it. We can't logistically make it. So what are we left with? We are left with our local environment. And the question is, why should the care in our local environment be any worse than the care we get at famous places? Big challenge and big vision, but I think a worthwhile one. Another few reasons about why Indiana. As you know, the Indiana Health Information Exchange connects lots of places, lots of healthcare places in Indiana. It gives us a vast range of opportunities. When you think about the fragmentation of information about patients in various care settings, having the INPC as an information source, both for clinical work as well as population health issues, is invaluable for us. And I think we should consider ourselves privileged to have that environment here. Second thing, somewhat ironically, IU Health is our first and main partner in the Learning Health Systems Initiative. They are statewide. You're talking about approximately 20 hospitals spread across the state. And then when you look at all the other members of IHI, you have pretty good statewide coverage. So I think it is actually, from an infrastructural perspective, we have lots of growth patterns and path already set to disseminate our learning health systems innovations. So how have we launched the Learning Health System Initiative here? Planning began about a year ago. We've had our program team in place for about 9 months. We have governance established, we have a program charter, we have good project criteria, and I'll show you those in a minute. These are the strategic aims of the Indiana Learning Health Systems Initiative. They read fairly bread and butter in terms of learning health systems goals. I want to highlight the fourth one a little bit: improve attitudes, perception, and engagement. That speaks to both care providers as well as patients, and I think that's a particularly fruitful potential area of engagement. Not that the other ones are not valuable, but I think there's quite a few wins we could make in this area. Planning was led by faculty from all centers of Regenstrief. It was one of the first times we kind of made another strategic initiative, that of the One Regenstrief Institute, a tangible reality in this planning process. But we also had input from executive and other staff from the health systems, such as IU Health and Eskenazi Health. The infrastructure by now is fairly mature in its initial draft. We have a set of committees. So at IU Health, we have the Executive Steering Committee, chaired by Peter, which provides strategic guidance to the Indiana Learning Health Systems Initiative. Underneath that sits an operations committee that is composed of more day-to-day managerial personnel, and they get more into what projects should we do, how should they be evaluated, what are the priorities. We have the program team, as I already mentioned, and which you saw on the first slide, and we have an external advisory board waiting to be launched. So we've identified the people on the board. We just haven't scheduled the first meeting yet. Whenever you look at an ambitious challenge such as the one I'm describing, you need to think about challenges. And so I've listed a few. One, IU Health isn't starting with this initiative on a learning health system path. IU Health has done many quality improvement projects over the years and is very active in that space now. But I would hazard the guess that we can't label IU Health yet as a learning health system. So the questions there are, how can we be aware of all the projects that IU Health is doing? And even after talking to many people at IU Health, it's quite clear that not even they are all aware of all the QI initiatives that they have going on. Once you know about QI initiatives, you need to prioritize them somehow. And our goal is to help prioritize them at a systems level, so that's another challenge. Within the system, as well as in healthcare in general, priorities change. The CMS turns out new regs that shift health system behaviors. There are public health crises, such as the opioid crisis, that suddenly dominate the discussion. So there's plenty of external factors that work on that system. And then last, as another challenge, you need to think about applicability to other organizations, especially starting with our local environment. How do you translate a QI initiative from Eskenazi Health to, from IU Health to Eskenazi and other hospitals? And of course, there are many more challenges. So this is a great point to bring out one of my favorite quotes from Machiavelli in The Prince. It must be considered that there is nothing more difficult to carry out, nor more doubtful of success, nor more dangerous to handle than to initiate a new order of things. For the reformer has enemies in all of those who profit by the old order, and only lukewarm defenders in all those who would profit by the new order. This lukewarmness arising partly from the incredulity of mankind who does not truly believe in anything new until they have actually experienced it. I see some nodding heads around around the audience. I think we've all, well, most of us have been there. Many times when you come with a new idea, a new concept, you face a lot of resistance. This is not going to be an exception. But the good part is we have lots of parties talking to each other. People appear to be energized, energetic. But in the end, the true yardstick of this initiative is the presentation I'm hoping to make in 3 to 4 years. What have we done to affect health and people directly day to day? And that's our yardstick. So with that, let me talk a little bit about the projects. I promised that I would tell you a little bit about the project criteria. One of the first ones is, can the project only be done by IU Health and Regenstrief together? If IU Health can do a project by themselves, let them do it. No problem. You know, he who travels alone travels fastest. However, in the discussions already become evident that there are synergisms between the two organizations that can really be leveraged. Is the project already in place? Does it exist? If the answer is yes, probably the answer is that our initiative won't touch it. Can the project make an impact rapidly? And impact, of course, can be defined in various ways. Can it be sustainable? And last, can we evaluate it? There's a number of project criteria lists coming out of other learning health systems initiatives, which we've looked at. And so obviously we will refine this list and the process leading to the project over time, but this is kind of where we start. So what are our goals for years 1 and 2, and where are we? So there's a red, yellow, and green legend there. Reminds me a little bit looking at Peter when he said to the advisory board, Learning Health System Initiative is done 40%. And the question was, what exactly is 40%? So here's a little bit more in terms of data. You know, what have we done so far? So you already understand we have the personnel and external advisory board infrastructure. We have a plan. Have made a little bit of progress to the first paper about the learning health system here. We did submit one major grant application that falls under this umbrella, and we'll submit another one in February. So we'll actually have two R1s pending very soon that are associated with the Indiana Learning Health Systems Initiative. We have CareView in production. I'll give you a small update about that in a second. We certainly have collaboration with IU Health. We haven't done anything with evaluation or visiting other systems to learn from them. In terms of some of the projects, so CareView is up and running for the collaborative filtering R01 that actually I'll present probably at my next WIP early in the year. We've gotten funding in June for that 3-year project. In one sentence, it will bring Amazon recommendation technology to medical information retrieval. So I know Amazon is big on people's minds with the holidays now. And think about it. What would it mean to have that level of convenience, prime delivery, returns, that level of comfort and convenience in medical information retrieval? We are currently starting data mining on a safety culture survey in which we will detect emotions within responses to a survey for which the data have already been collected. So we're actually leveraging some text mining tools to do analysis of emotions and sentiments. So that's a really cool project. IU Health has talked a lot about variation of care, social determinants of health, as well as physician engagement, burnout, and reducing documentation burden. So these are some areas which we're currently exploring. As you probably can tell between the lines, most of the active projects came out of Regenstrief. Some of them were my projects that I simply rolled into the initiative. But the initiative wouldn't really be alive if IU Health didn't say, well, here's what we care about. And then we worked on their priorities. So at the moment, we're actually working very hard with the two committees that I already mentioned to generate a list of ideas for refinement and launch in January that speak directly to IU Health's priorities. And we'll talk about that in a second. Obviously, I'm also very much interested in welcoming your ideas, and we'll spend most of the remaining time on that. Before we do that, a little update on CareView. So you may know CareView as previously called as the fire hydrant. So that was the chest pain app that we rolled out in March. It has been alive and well since then. And we have added 6 more chief complaints to the app, which are all now live. So now as a clinician in the EDA, you can choose any one of those 6 conditions and get a targeted set of information items from the Health Information Exchange for that. Those list of items are fairly complete. We still have one work item on that, which is lab tests, which is kind of a bigger challenge in terms of fire implementation, but in the next few months we'll actually have the lab tests with those things too, and then that'll make for a fairly complete quote-unquote version 1. So this is what it looks like right now. So you see the chief complaints here, the customized lists of data elements here. So as you click down here, this will actually change. And then when you click on one of those elements, you actually get the detailed report. As you may imagine, there are some elements which appear on almost every one of those chief complaints. So for instance, hospital discharge, last discharge summary is something of interest in almost all of them. So what are your ideas? So this is, as I said, I want to spend some time discussing those. How to improve community health, how to drive quality improvement, lower costs, or a quote from Dennis Murphy, bring the joy back to medicine. And with that, he kind of embodies he connotes a feeling of less hassle in the clinician's job. We know that the clinical time with the patient has boiled down to something like 12 minutes out of every hour. So, you know, remind yourself, we're paying for a very expensive resource, the physician, and lots of time of theirs is spent on clerical work, you know, navigating through computer systems, recording stuff, documenting stuff so CMS is happy. And the question is, how can we swing the pendulum back from the boredom, sense of doom, frustration, pessimism that results from that, and make medicine more fun? And this is not an idle question. You've all heard about the issue of physician burnout. It actually has an impact on the labor force. Clinicians are retiring early because of the changes that happened in the last 10, 20 years. Not a good trajectory. And so what can we do to reverse that? So with that, let me close the presentation part of this and invite you to tell me any and all of your ideas for the Indiana Learning Health Systems Initiative. It can be something you're working on. It can be something you have just a mere notion of that it is a great idea. I think there is a huge potential to be realized by associating projects with the Learning Health System Initiative, feeding back ideas to this and the extended researcher community to spark new research, applied research questions. So I think, as you can tell, I'm really excited about this initiative. I know Peter is too. And so let's make this a reality together. Thank you very much. Questions, suggestions? Yes, Steve.
So I'm going to do a brief philosophical rant, which I think you sort of invited. So I think I'm actually starting an editorial about this. So if anybody wants to join in, let me know. But okay. I think that our system of health quality and, you know, paying for quality is badly broken, and there is a way to fix it. But if you consider the way it's done now, physicians are trying to practice. They're two leading, according to Rand, their two leading dissatisfiers are tied: the EHR and the regulations that they have to meet to satisfy payers. And the regulations largely come from the fact that someone outside wants to say, are you providing quality care? How are we going to tell if you're providing quality care? And that has resulted in quality metrics, which have tons of problems. They have the drunk under the lamppost problem, which is that you look where the data exists, and that means you look at administrative data, which bear a very weak resemblance to the important parts of care. Yep. Two, they cost a fortune to measure. A couple of years ago, there was a paper that showed it costs about $25,000 per physician per year to capture quality metrics. And three, they can be very distracting, because if you spend all your time trying to improve the quality and usual quality of care processes to improve three things, right, the other 100 things go out the door. So I think the right way to do this is if we want to improve quality of care, it's at the efferent end of your of Chuck's graph, which is to provide, if we want to improve the quality of care, we need to drive the decision support to improve the quality of care by providing an easy, structured way for physicians to see what needs to be done for a particular patient and provide that care in a way that captures the data that they are doing. So if you capture risk factors that put a patient in the denominator of a quality metric, and you capture the physician's response to that then you have the numerator of that same metric, and the quality metrics just fall out as a side effect of driving the quality of care. So I would say that the one thing, for example, that's missing in CareView is you've got the first part of the efferent arm, but you don't have a quick way for the clinician to say, well, here's what I did about it. You're giving them data that could be used as a denominator, but not what could be used as a numerator. Once that's done, the documentation that you're asking for from the physicians is always actionable stuff. You're not just collecting data for the sake of collecting data. Kurt and I had a conversation the other week about promise metrics, which are largely unactionable, but if you're asking physicians to document things, it should be actionable. So you reduce the burden on the physicians, you capture quality metrics as a complete side effect, and you drive quality, and all that happens automatically.
Very good. I would be interested in comparing what I could write based on the notes I took from your philosophical rant and compare that to your editorial that you're working on. It would be so stellar if it was the same thing. So, wonderful statement of a big problem. And so I think there are many, many things that we could make easier, and you've pointed out quite a few of them. I'll just highlight one thing. This is Peter's favorite term. Let's blow up physician documentation. And we actually had a project like this on our list. At the moment, it is in a semi-suspended, not really dead state, but Cerner decided that it was going to focus on artificial intelligence as opposed to making physician documentation easier. But hopefully they'll see the light again and revive this. But one of the ideas there is to say, let's blow up documentation, let's have embedded computing in an exam room, generate some really high quality recommendation, and Mark has presented this here, if you remember, and then say to CMS, hey, we can do this with much better documentation with the side effect of QA and QI, and not have people fill out the checklist medicine paradigm. So great suggestion. Other suggestions?
I have two comments. Yes. One is high level. I mean, a few things you touched on were the engagement, that fourth component of the slide that you had up. How do you engage the end user in this learning health care system? Or what specifically does RI do around that? Meaning the patients. And two, there is a big push towards social determinants of health, but we realize that most of what we need is not in existing data sources. And what's RI's approach to
Very
that?
Good question. Yeah, very good questions. So engagement, as you know, it's two things: engaging the clinical personnel as well as engaging the patients. I haven't seen much about learning health systems engaging patients, and I actually want to engage patients even in what we are doing right now. So I've been thinking about that. So of course, my first stop will actually be to go to IU Health and say, hey, how are you engaging patients at the moment? Beyond the, I forgot get the company's name where you get the surveys from. So there's a famous, say again? Yeah, there's a company that makes it a business to administer patient surveys for healthcare institutions, which are ultimately useless. I mean, IUH says that. So how can we meaningfully engage patients? Very good question. What is the Regenstrief doing about the social determinants of health? So one other strategic initiative is the Indiana Network for Patient Health, or population health, which includes social determinants. And so another item I would point you to is Sean Grannis's, Josh Vest, and many others projects. Aranga is on this. Upsturms, which just won the EMEA Pitch competition just about a month ago, which also focuses on social determinants and social referrals, actually, for social support among patients. So I think we've recognized the space. Peter's leadership on this has been very obvious, and I think we'll see actually a lot more fruits in this space in the next few years, which I think will be great, because for the most part, it's not there.
And then my second question is, we just recently got a PCORI LOI accepted, and we're working on the proposal right now. There's definitely an opportunity to partner here, and it could be with taking that chest pain app one step further. Everything we need to determine whether a patient is low risk chest pain is in the EHR, except for two components. And rather than screening those patients in the typical research fashion, it'd be really great if we had something that popped up that gave, a preliminary risk score, and then the doc could enter the last two components of the chest pain score.
Let's talk after this.
Okay. Yeah.
Because I'm reminded that I will be killed if I don't finish on time. Mike, where are you?